It is an honor for us to host you, Professor Rachel Bוכבינדר and Professor Ian Harris. I'm excited and glad to say that Ariel University and Asuta Medical Center in Israel have taken the initiative of raising the topic sustainability in medicine, and our conference will be dealing with too much medicine. Please allow me to present you to the conference attendees. Professor Rachel Bוכבינדר is a physician specializing in rheumatology, director of the Monash Cabrini Department of Musculoskeletal Health and Clinical Epidemiology at Cabrini Hospital in Australia. She is known internationally for her landmark studies, particularly those examining treatment accepted into practice before proper evaluation. She is in the top 1% of the world's most cited scientists. She is the Cochrane musculoskeletal editor, and she herself has written more than 100 Cochrane reviews. Thank you, Rachel.
Thank you.
Professor Ian Harris is an orthopedic surgeon and an honorary professor at the University of Sydney, Australia. Known internationally for his surgical trial and published more than 300 scientific papers. He is the author of the book, Surgery, the Ultimate Placebo. So I will start with you, Professor Harris. Why did you decide to write the book, Hypocrisy, How Doctors Are Betraying Their Oath?
I think the main reason for us writing this book is to balance the perception of medicine, because the perception of medicine is that everything we do works, that medicine is wonderful, that more medicine is better, and the truth is somewhat different to that. So the truth is that a lot of medicine that we do is either not effective or harmful. A lot of it is wasted, and this message is not well appreciated in the world, either by the public or by doctors and health practitioners themselves. So we wrote this to kind of balance that perception and hopefully put a more realistic perception on medicine and what doctors do.
Mm-hmm. Professor Bוכבינדר, who did you write the book for? For patient, for doctor, for who?
So we initially really set out to write the book for the general public. So we wanted it to be a lay book, not a textbook for doctors, but we hope that doctors read it and other health professionals read it as well. So that was our aim, that it would be understandable to the general public in particular, but the clinicians would also read it and appreciate the messages in there.
Professor Harris, can you explain what you mean by too much medicine?
Too much medicine is when we carry out medical procedures, surgical procedures, prescribe drugs, basically medical treatment that doesn't help people. So that's really over treatment. It's too much treatment. It's either unhelpful or harmful.
Maybe Professor Bוכבינדר, can you give example of what you call medicalization?
Sure. So as Ian said, medicalization describes the process by which normal human conditions come to be both defined and treated as something medical. And these can be things that we experience, all of us experience, like grief or sadness, and it might be in response to something that's sad, but it's turned into a medical condition. It can also be things that are thought to deviate from what is called normal. So it might be outside a range of normal, or in past things like being attracted to the wrong sex was considered an abnormality, and it was medicalized, and people sought medical treatment for it. So it can also arise when people make up new diseases, and we can talk about that a little bit later, but it might be diseases related to aging, which is just a normal process that hopefully we all go through, and how that's turned into something that's medical and therefore abnormal and therefore needing to be treated. And there are lots of examples. So there are things like anxiety, sadness, grief, thin bones, thin weak muscles from becoming older. All of these things have become medicalized over time.
Can you give example of overdiagnosis?
Sure. So overdiagnosis occurs when someone is given a diagnosis. The diagnosis is actually correct, but it will not give them any benefit to have that diagnosis, and it often will cause harm as well. And it can occur in both asymptomatic people. So perhaps if they're being screened for cancer and a cancer is found, it's a real cancer, but it will actually never hurt them in their lifetime, and it doesn't really need treatment, they'll be harmed by the fact that it's now labelled as cancer, and often those people will get treatments that they didn't need, and then there are the harms that can come from the treatment. But it can also occur in people who are symptomatic. So, for example, in our field of back pain, someone can have some back pain and they're sent off unnecessarily for a test. And on imaging, something is detected and they're labelled with that condition. And it might be totally irrelevant to their back pain, but they might receive treatment for that, such as surgery, and then be harmed. It can also be what I was already mentioning, creating new diseases or treating risk factors as diseases. So, for example, treating high blood pressure as a disease in its own right rather than as a risk factor for heart disease, for example. So there are lots and lots of examples of overdiagnosis, and many of them we outline in the book.
Professor Harris, can you give example of overtreatment?
Well, I can give lots of examples of overtreatment. It's been estimated that somewhere between a quarter and a third of all the medical care we provide is not necessary and would classify as overtreatment. And overtreatment can be something very simple. It can be just writing a prescription of antibiotics for the common cold, for example. That's an example of something that can possibly lead to harm, and it's a treatment that won't help the patient. But it goes much further than that. And in my field of surgery, there's many examples of common operations that are considered overtreatment. And these could be simple things like keyhole surgery in the knee for knee symptoms, but it could also be quite major surgery, such as spine fusion operations and things like that, where we don't have good evidence that this helps people with chronic low back pain. And yet it's a very invasive, very risky and very expensive procedure. And I would consider that to be overtreatment.
Maybe Professor Bוכבינדר, can you give example of medical harm?
So medical harms, medical harms can occur both from necessary care. So that can be, the risk of a complication from a treatment that is actually necessary. So that might be an adverse effect from chemotherapy, for example, for a person who has cancer and where we know that chemotherapy will help them. But there is also the harm that can arise from unnecessary care, and that's what we're most concerned with. When people talk in the literature about medical harm, a lot of the work's been done calculating the medical harm from going to hospital and being in hospital and all the complications that occur in there. But what isn't taken into account is the harm that comes from unnecessary medical care, and people just assume that the care that they've received is necessary, and that the harms are just something that they have to bear, and everyone bears that risk. But we know, as Ian said before, well, I think he said it before, I'm getting confused, that 10% of what we do is thought to be harmful. We know that 30% of what we do is not helpful, is wasteful, but an extra 10% is actually harmful. So it doesn't cause benefit, but it causes harm. Mm-hmm. And there are lots of examples from history. So an early example is thalidomide for women with morning sickness. And the biggest example currently is the opioid epidemic, with predictions are that the number of deaths from opioid overdoses are set to rise. And it's really, really hard to get people off opioids. So we have to really be sure that what we're doing it might be helping them in the initial part, but if the long-term harm is that they're going to die from an overdose, it would be much better if we didn't have that treatment in the first place.
Professor Harris, you wrote in the book that modern medical care has been packaged into a business model, and it's not suitable for it. Can you elaborate?
Yes. For many people, they consider that the typical capitalist free market business model is a good way to provide a product. And it is. It's very suitable for many things. But it's not very suitable for medicine, which is a necessary service. And what happens when you privatize or you apply economic principles to the delivery of medicine, you find that it doesn't fit very well. And so, for example, at one end of the scale, people will be shut out from obtaining medical care that they need because of costs. But at the other end, it drives over-treatment. It drives more medicine. Because if you're looking at, again, I tend to talk more about surgery because that's my area. But if you look at surgery, the whole business model is for more turnover. I mean, the private hospitals make more money with more operations. The doctors make more money with more operations. The pathologists, the imaging doctors make more money with more scans. That's how they generate profit. And so success in medicine becomes a turnover and profit, not health. And what we tend to measure, even in the public sector where profit is less of a motive, we tend to measure performance in aspects of healthcare or the provision of services, not in the health of the population or improvements in health, even at an individual level.
Professor Bוכbינדר, how medical care is supposed to work?
So at its very simplest, medical care is supposed to improve the health of the person who's receiving the medical care. That's the essence of medical care. It's supposed to be based on the best available evidence, coupled with maybe the doctor's expertise and experience and the patient's preferences and what other factors are going on to help them to decide the best treatment for their circumstance. Healthcare is meant to be empathic and compassionate. It's meant to it's meant to in an ideal world, your practice of medicine will change as new evidence becomes available, and it turns out that we should do it this way and not that way, and we should stop doing that and we should start doing this. But that's not the way that it works. And it's also making people over-reliant on medicine. We seem to be going to the doctor for every little thing rather than considering self-management, being resilient, and that's really a societal problem, I think, that it's consumerism, wanting everything to be fixed, and seeing older people who are unsure why they're falling apart, and you have to explain that they're 90 years old and they don't actually understand. So I think we have a lot of work to do to change the public perception of what medical care is and what optimal medical care is and what it isn't, and how we're harming society.
Professor Harris, you claim in the book that it's been estimated that less than half of the treatment prescribed today are supported by adequate evidence. This is scary and disturbing. How can it be?
I've done some research in this area, and it's mainly been around surgical procedures. Other people have done research in other areas of medicine, such as gastroenterology or pediatrics or general practice. But commonly, when this has been looked at, it's found that a lot of what we do does not have good scientific evidence to support it. Often things are done because we think they work, or we have reason to believe why they should work, but we don't have evidence that they do work compared to not doing them. It's very common in surgery, but it happens in all fields, in physiotherapy, other health professions as well. And for surgery, often a new operation is brought in when somebody thinks that this is a good idea. And so they perform the surgery. Often they will see people who say they feel better afterwards. And then they will attribute that improvement to the effect of their surgery, when a lot of people with a lot of chronic conditions or fluctuating conditions or self-limiting conditions will improve anyway. There's so many examples. I'll give an example which was a personal one for me, because I recently had tennis elbow, or pain in the elbow, and there's many people who still do surgery for this, and there's other treatments such as various injections that work, and surgeons who operate on this firmly believe that their operation is effective because nearly all of the patients they operate eventually improve. But we know from the natural history of the condition that nearly everybody will get better within 12 months anyway. And so if you do anything to those people, they will get better. And it's a human error. It's a shortcut that we take, a logical shortcut, which is false, that we attribute causation when we see one thing follow another.
How can clinical observation be so wrong?
Because it's an illusion. There's so many classic examples of illusions. This is why spiritual beliefs, some religious beliefs, sacrificing people to get a good harvest, or sacrificing a goat, but also the medicine man, the shaman. Throughout history, there are people who believe that just because they did something and something else followed it, that it followed because of what they did. And to bring it more closer to modern society, I mean, I have seen many people, and my own family included, who have their own remedies for the common cold, and they all work because the cold gets better anyway. And so that's the problem, is unless we do proper scientific studies where we divide people into groups, and one group gets the intervention and the other group gets everything else except the intervention, and then we follow those two groups and we compare them. That's the scientific test. But humans don't think like that. They just think that this should work. They see people get better and they assume that they got better because of what they did. It's a very powerful logical fallacy that humans have, and it's difficult to overcome.
Professor Bוכbinדר, why practice, after we know all the evidence, why practice change is so slow?
Well, it's been estimated that it takes about 17 years for evidence to change practice. And I think there's a wide confidence interval around that. And there are lots of reasons. I think one of the things that we don't often appreciate is that getting the evidence is fairly recent in human history. So we're not used to having to do that, although in our generation, you'd hope that people were used to it already. I think the actual 17 years bit is that you have to do the study, you have to write it up, you have to send it off to get published. Some studies never get published or never get written up. It has to get accepted in the journal. It has to then be published. It has to be widely read. People have to accept the results. People have to often change their beliefs. And all of these things take time, and there are many things that stop that from happening. So many people are resistant to change. They have their fixed beliefs, and if a study comes along and it's not what they believe is what they expect that the results will be, they'll often dismiss those results, and that often leads to conflicts and blaming the messenger for doing a bad study because it didn't produce the results that they know to be correct. There's also lots of magical thinking, and when there's uncertainty, people just assume that it works, and it's very hard to shift these ingrained beliefs. And this is putting a positive spin on it. I haven't even talked about the vested interests that promote dodgy treatments because it's lucrative. But I think most doctors want to do the right thing, as Ian said before, and a lot of the problem is these illusions and this real lack of science literacy. So we don't think that doctors really understand how to understand the evidence, and they'd much rather believe their biased views than unbiased evidence. So I think we have a long way to go towards shifting that, and I think it will take a long time, and it will rely on more and more people understanding, and then it will hopefully tip towards the standard of care always being to look at what the latest evidence says. But I think it's going to take a long time. And I should say it's also a huge amount of literature to actually have to keep up with. So we try our best to synthesize the evidence, but then it's got to be, people don't read Cochrane reviews. You still have to do shortened summaries, and then you have to have guidelines, and then people have to write the guidelines, and people have to agree with the guidelines, and then the evidence changes and it's out of date. So there are lots of obstacles, but we think that that's what we should be doing, and we should be making every effort to do that by changing the system.
Professor Harris, can you elaborate on the surgery placebo trial?
Yes, so most people understand the concept of a placebo-controlled study in the drug world. So if you're testing a new drug, you can see how comparing that drug to another drug that does not contain any active ingredients but looks the same is a very good scientific way of determining how effective it is, because you've made everything the same except the ingredient of the pill. And so you've in effect blinded everybody in the study, or in particular blinded the patient, so they don't know what they got. So their own personal biases, their expectations cannot come into the comparison. So that's the best way of testing a drug. It's not really well understood that this can be applied to surgery. And certainly there have been placebo-controlled surgical trials, and these are becoming more common. And it's the same principle in that a patient can have a similar looking incision. So, for instance, there's been studies on knee arthroscopy. So the patients will have a few small incisions in their knee, and some of them will have the full surgical procedure, and some of them will not. They'll just have the incisions, but they will be asleep, and when they woke up, they won't know what they had. So the beauty of that is that it is a better scientific method. It's a better way of achieving an unbiased estimate of the true effectiveness of that operation. Because if you don't do that, then you have a situation where you're saying to the people, oh, you'll have the operation, we'll put you into surgery and we'll do that procedure and we'll see how you go. And the other group, you're saying, well, we're not going to do anything for you. You can go home now. And so you can see that there's a big difference in the expectations of that patient, how they might react, how they might see their symptoms differently. And so and this is particularly important if you're treating a subjective outcome. So if, for example, you're doing an operation that corrects a deformity in somebody's leg, you don't need a placebo operation because you're measuring the deformity on a radiograph or on an X-ray. It doesn't matter whether the patient is blinded or not. It's an objective, measurable outcome. But if you're doing an operation for pain, we know that the reporting of pain can be very subjective to other things that are happening around the patient and what they expect and what they think they've had. And so it's very important in surgical trials for pain or subjective outcomes to have a placebo control, to properly blind the patient and to blind the other people in the study as well, the people doing the follow-up, for example.
And I might jump in there and say, I think it's equally important, seeing this as a physiotherapy audience, that there be placebo-controlled trials of physical therapy as well. And again, you can blind patients to think they've had what the treatment part of the physiotherapy is. And in those studies, often we find that for example, there was a recent trial in the Lancet looking at exercise for shoulder pain, showing that it doesn't make any difference. So I think if we're being honest, we have to think about placebo-controlled trials for everything that we do in medicine.
Professor Bוכבינדר, the chapter on the cancer screening about the breast cancer and prostate and thyroid was overwhelming in the book. You called it an epidemic of diagnosis. Can you elaborate on this topic?
Sure. I mean, that wasn't our quote. That was a quote from a study that was looking at the rising incidence of thyroid cancer with no change in the mortality. So no change in the death rate, but just a rise in the incidence. And the study authors, the quote was something like, this seems to be not an epidemic of disease, but an epidemic of diagnosis. And so what they mean by that is that the more we screen, if we do screening tests and all we're doing is finding earlier cancers or cancers that will never harm you, and the death rate is not reducing, then that's really a sign of overdiagnosis. And there are lots of examples in screening where it can be highly debatable about whether mass screening should be done. And mass screening for thyroid cancer is one where it was proven that the screening itself was actually harming a lot of people, particularly young women, who then, when they had a cancer diagnosis, they'd have their thyroid removed, often their parathyroids. They would be put on lifelong thyroid replacement. Some of them would be, their vocal cords would be paralyzed, and all because of a diagnosis of cancer that probably was never going to harm them in the first place. Not to mention a big scar. And a lot of the early cases were actually in female radiographers. So they would be doing these ultrasounds and I think probably just looking at themselves as well. So I think it's a really important lesson that if you're thinking about having screening for any type of cancer, that people do their homework and understand what the benefits might be. Sure, you might pick up a cancer that was going to kill you, but at what expense? How many cancers are going to be picked up that won't kill you and are going to be harmful from, firstly, the psychological distress of having a diagnosis of cancer, and then whatever follows after that.
What can doctor do differently, Rachel?
I think the biggest problem is the lack of science literacy among our doctors. If people truly understood how to understand evidence, then we would be far better off. If people could be removed from their fixed beliefs, if they could be explain things to patients, explain what the evidence is in an honest way. So, for example, if someone went to Ian and said, I want an arthroscopy, I would hope that Ian would explain what the evidence says about the benefits and the risks and the fact that it's not going to help me and it might harm me. But at this stage, I can't see that that's happening enough. I don't think that the doctors are doing that deliberately, but again, it's about all the things we've talked about, miracle thinking, lack of science literacy. Some of it might be lack of empathy for the patient. And what Ian likes to talk about is what's it called, moral hazard, or where the doctor's taking no risk for themselves. They're doing something, but all the risk sits with the patient. So I think that there's an onus on doctors to really think about what they're doing and think about whether there's a better way and whether, I mean, it's hard to do. And I think it starts in medical school.
How can patients refuse diagnosis and treatment?
Well, I don't think we're advocating for patients to refuse diagnosis and treatment. I think we're advocating for them to be a little bit more skeptical and to ask their doctor or their other health professionals the right questions. And there are plenty of lists of questions that patients can ask their doctor. And, the choosing wisely list is one. So things like, what are the alternatives? What are the benefits and risks? What would happen if I do nothing? And then if they're not satisfied with the answers, then they could always get a second opinion. And I don't think patients should be afraid to get a second opinion. And it's hard for patients. There's a lot of misinformation, as we know. And so we need to actually have some way of directing patients to good information and not bad information. And again, that often rests with the doctor as well.
Professor Harris, can patients change the way healthcare is delivering?
Yes, and that's one of the reasons why we're appealing to the general public as well as doctors, because I think there's a role for both. Our main aim is to have health professionals and patients be more scientific and to be more aware of the scientific method and how we compare things and how to judge the effectiveness of things, to be aware of the fact that a medicine or a treatment prescribed for them may not actually be necessary or may be harmful, and to ask more questions. Can they change the way we deliver medicine? That's yes, because I don't think doctors will change it. Particularly when there's a profit motive in medicine, which is not always the case in every jurisdiction, but it's very common. And I think that the people that need to change medicine is not just doctors, but everyone else. You know, it needs to be from policymakers, from governments, and from the population to say we want better, because so much money in the expenditure that's put out in every country goes towards the delivery of healthcare. I mean, it's a huge budget item. This is not a small thing that governments fund. It's a huge thing, and it could be done so much more effectively. And people tend to chase the very expensive treatments that have very small marginal gains or no evidence at all, instead of less attractive, very cheap, broadly applied public health options, you know, and even extending beyond medicine to, you know, just educating people better, because then they will have a better understanding about the decisions that they have to make around medicine. So I think, yeah, there's a lot that can be done, but I personally think that a little bit less private focus and a bigger focus on perhaps less sexy or appealing things, but you know, more public health oriented approach is how we can make things better for everyone.
Professor Bוכבינדר, how can universities help new generation of medical students avoid the pitfall outlined in your book?
Well, the very short answer is make our book required reading and test them on it. And I think they have a responsibility to teach evidence-based medicine, really, to teach evidence-based medicine, to teach students how to communicate effectively and how to do that, how to communicate with empathy and compassion. And I think we haven't mentioned it yet, but healthcare contributes significantly to the carbon footprint, and that's an existential crisis. And I think that medical universities also have a duty to teach medical students about the environmental impact of healthcare and how we can reduce that towards carbon neutral healthcare.
Wow. Thank you so much for this inspirational interview. I hope that the interview with you and the book you wrote will also help us here in Israel to begin a process of working together with all medical staff in order to improve health and well-being. Thank you so much, and we hope to see you here in Israel soon. Thank you.
Thank you.
עכשיו נקווה שנראה אותם. יש למישהו שאלות? ניתן איזה... יש? שלחו לי 2? לא רואה, אז אני אשאל רק את 2 שאלות, אם נראה אותם. הנה. Hello, Professor Bוכבינדר. And hello, Professor Harris. Good morning from Israel. And good evening for you in Australia. Hi. So we have 2 questions for the audience. I will start with you, Professor Harris. Do many health professionals agree with you?
Yes, many do, but certainly not all. So there is a movement of health professionals who are aware of the problems with too much medicine, with overdiagnosis, overtreatment, and unnecessary care. And there's a considerable amount of research done in this field as well. But by and large, it hasn't really penetrated throughout the medical community. And it's certainly not seen by the public as well. And so the public's view of medicine is that everything we do is helpful. And they seem to be disbelieving when we tell them that a lot of the things we do don't help. So yeah, I think many do agree. It's a science, you know. So we make scientific arguments, and you know, many people listen to that. So it's not as unusual as a lot of people think.
Okay. Thank you so much. And another question from orthopedic surgeon also, Amir Rubin, please.
Good evening. Extremely impressed. I know your work, and I'm a follower. I hope to call myself. You spoke about the disbelief, the questions we have about the medical treatment that we have, and you showed some research that support that we're not sure what we're doing. Do you have research about crossing that point over, about implementation? I actually represent the system. I'm the public. I work in a healthcare organization, and I would like to know if there was research done about how to convince people that we're giving too much medicine.
Yeah, well, there's been considerable research done in practice change, which is really what you're getting at. And it is interesting because when I started down this field, I thought as soon as you get a scientific finding, as soon as you have a study that shows, for example, that this operation doesn't work, then everybody will immediately just change practice the day after the publication is released. But of course, that doesn't happen. And so the research tells us that the way doctors practice and the way they change their practice is very much a social phenomenon. It's not necessarily a scientific phenomenon. You need the scientific basis on which to found your change, but the change occurs because doctors are more comfortable doing what the doctor next to them is doing and what the other doctors in their practice and in their hospital are doing. And so to change that, you have to do it very slowly and gradually, and you've got to have somebody lead the way, and then somebody follows that person, influencers, I guess you would call them. And yeah, it's not an area of specialty of mine, but certainly there's been considerable research, and I think probably Rochelle knows more about that field than I do, so I might hand over to her.
Thanks, Ian. I mean, there's certainly lots of evidence now about how to change behaviour, and you can do that with doctors, for example, with audit and feedback. And we've recently done a big national study with the Australian government trying to reduce low-value musculoskeletal imaging for 11 common conditions, 11 common imaging, shoulder, knee, etc. And just using very simple audit and feedback over 18 months, and even during COVID, we've reduced the number of tests overall by about 47,000. So you can certainly change practice, and there are lots of things that will happen overnight, and often things that are implemented into practice before there's high quality evidence get implemented very quickly. Vertebroplasty, think PRP injections, think hyaluronic acid. They're all embedded in clinical medicine before they've been evaluated, and they've all been shown subsequently not to work. So I think we have to be smarter about introducing new treatments and make sure that we understand the evidence before we implement. So it's always easier to not implement than to try and de-implement. And in terms of changing patients and the general public, there's evidence that things like our mass media campaign changed beliefs of not only the general public, but doctors. It changed their behaviour. So there are lots of different ways that you can influence behaviour and there's lots of theories behind how to change behaviour, and I think that we can do it, and we can't wait 17 years anymore for evidence to be for evidence to change practice.
Yeah, I think I'll just add to that, because you did say that you're operating at a system level. I think at a system level you can make bigger changes. I mean, by not funding certain things you can do it, but we've learned from experience that, as Rochelle said, it's a lot harder to remove funding for something that's already funded, instead of to have a system in place where it's not introduced in the first place, or not funded in the first place until it's proven to be effective. So, yeah.
Thank you so much for the interview and the book you wrote. And everybody, I don't know if you see the crowd, very happy. You don't see, so everybody is happy. Thank you so much, and we hope to see you here in Israel soon. Thank you so much.
Thank you.
Bye-bye.
Bye.